Good morning, and it's a pleasure to speak to all of you. And we're going to be talking this morning about common pulmonary problems of the elderly. Basically, I do a lot of this because most of my patients are elderly with lung diseases that we see generally that occur in older individuals. There are a few like asthma and allergies that we obviously see, but the ones that I'm going to be speaking about are generally those that are seen in older individuals. So next slide, Megan. So one of obviously the most common lung problems that you and I will see is COPD, chronic obstructive pulmonary disease. Generally, but not always, there's a history of tobacco use. And it's generally significant. It's usually over 20 pack years. And in people that are older, it may have been that they've quit for 10 years or 15 years. And if you ask them if they smoke, they'll say no. But if you ask them if they've ever smoked, they'll tell you, they obviously give you the history. So you need to, with every patient you have, need to take a history of their tobacco use. If they have a significant history of tobacco use, even if they do not seem symptomatic, many times patients with COPD are not symptomatic but have significant obstructive disease, and many times will not exhibit any significant problems that they perceive. If you talk to them closely, many times they say, you know, I've been getting older, I walk more slowly, but I know that's just because I'm getting older, etc. And they really have adapted to their impairment to the point that they can still function, but they are really limited and don't really realize that they just backed off from what they can do. So if you have a significant pulmonary history, if you have access to a spirometry, I would recommend doing that, because many times you're surprised. Many times I'm surprised a patient will come in and they don't look like they're really sick. They say, you know, I've just noticed over the past 6 months I'm short of breath. And when you really get down to it, they've gradually been getting that way. And then when their FEV1 gets usually around 1 or less, that's when they have symptoms that occur with daily activity. And that's when they date their shortness of breath. So you don't want them to get to that point, especially if they're smoking at the time you see them, because you want this as part of your help to convince the patient to stop smoking. So if you get a spirometry and you show the patient they have severe obstruction, many times that'll be helpful in motivating them to quit smoking. Once you identify that they do have COPD, the primary treatment is the use of bronchodilators. And predominantly, if it's mild disease, we usually start with something like Spiriva or Incruz. And many times that's all they need is their controller medication. These drugs have been shown to, if the patient is not smoking, stabilize the reduction in FEV1. So they're add-on to a patient, even if they're really not too symptomatic. The other approach that some people do if they have very mild disease is to just give them an albuterol inhaler if they get congested or wheeze or cough, and they'll have something as a rescue inhaler. And everyone should have a rescue inhaler if they have COPD. Beyond that, if they have moderate to severe disease, you might want to move on to a combination of something like Spiriva with a long-acting beta agonist, and Stiolto and Anoro are two examples of drugs that are a combination of the two that are very useful as the next step up in therapy. There are drugs like Trilogy, which is really like Anoro or Incruz, Anoro or Stiolto, with an addition of an inhaled steroid. And that's an appropriate therapy in patients who have an asthmatic component to their problem. As many of you may know, inhaled steroids increase the risk of episodes of bronchitis and pneumonia over time. So they should be used in context of an asthmatic component and not used if the patient just has pure COPD without an asthmatic component. In a way, you can look at that in terms of reversibility if they are given inhaled bronchodilators and they have a significant reversal in their FEV1, improvement in their FEV1, then they might indeed have an indication that they have reversible airway disease, and an addition of an inhaled steroid to the other medications would be appropriate. And the other thing is, if you get a CBC and they have a lot of eosinophils, that's a hint that they have an allergic component or an asthmatic component to their COPD. And that might be another indication to add inhaled steroids. Otherwise, I try not to use the inhaled steroids in these folks because they're very vulnerable to infections, and the inhaled steroids over time may increase that risk. The mobilization and rehabilitation is important, and you try to do that as best you can in the COVID era. There are remote rehabilitation programs. UAB has one. I'm sure there are others available. And you might want to look into that for your patients if you feel like rehabilitation would be helpful in their COPD. These remote facilities send the program and line it up for them. They have people that work with them that'll line it up for the patient. So it can be done if you order it. And I found over time that rehabilitation is helpful, especially in getting patients mobile and strong, and also teaching them breathing exercises and helping them stop smoking. So smoking cessation is the other thing that's very helpful. And it's amazing to me how many times through the years I'll tell a patient they need to quit smoking, and they'll say, you know, if a doctor ever told me I should quit smoking, I was going to quit. And you're the first one that's told me that, so I'll quit. And, you know, it's funny that we as physicians don't say that often enough to our patients, that we ask them to quit smoking. I think these days people are doing that more commonly, but years ago that was not as common because many of the physicians smoke themselves. The other thing is treatment of infections and exacerbations. You want to really treat them if they start coughing purulent sputum. And then in addition, some people will use Zithromax as a suppressive antibiotic. And there are two ways that people do that. One is to give daily Zithromax. Another that's many times more tolerable to patients is to do it 3 times a week, like Monday, Wednesday, Friday. And this over time, there was a New England Journal article years ago that demonstrated that use of Zithromax on a regular basis reduces exacerbations and episodes of infection in patients with COPD. Okay, Megan, let's move to the next slide. So obstructive sleep apnea, the main thing I wanted to bring out about this is hypercapnia. I don't really evaluate or do sleep studies. That's not part of my practice, but I do see a lot of patients that have obstructive sleep apnea and a lot of patients that are on devices, CPAP, BiPAP, even Trilogy ventilators at night because of significant obstructive sleep apnea. And these patients, of course, present with snoring, apnea, daytime sleepiness, and then you should get them studied if you see that that's part of the history and you suspect they have it, and then you get them on the appropriate therapy for obstructive apnea. But the thing to remember about people with obstructive apnea that's very important in your practice is to avoid medications that suppress respiratory drive. These patients are very sensitive to anything that suppresses central respiratory drive, and that would include narcotics and pain medications that are suppressive, and benzodiazepine drugs, or any drug that will suppress respiration. So it doesn't mean you can't use these things, but be aware that they may have a problem with it, and make the family aware as well. So that a lot of times if I get a patient like this, I'll get a blood gas because if I don't know what the PCO2 is, many times I won't know how severe it is. There are many patients that have obstructive apnea. They have fairly good respiratory drive in general, and they'll do fine. But if you find a CO2 retainer, you really need to be very careful with them in terms of their medications. And also, you need to be very careful in terms of the type of ventilation that you're going to deliver them, so that many times these patients come to me and they're having problems with shortness of breath, and the family says they're sleeping during the day, but they're on their CPAP every night and they're very compliant. But I'll check a PCO2, check an ABG, and the PCO2 is 60, and they're on what would be an appropriate therapy. So many times you have to move to things like Trilogy, an actual ventilator, to really get them ventilated and drive their CO2 down and be able to rest their muscles of respiration during the night. And many times you can bring their CO2 down to some degree. That also applies to surgical procedures and precautions, because if these people are CO2 retainers or they have obstructive sleep apnea with blunted central drive, they wake up slowly. They may become apneic post-surgery, especially if they're given a lot of pain medications post-surgery. So these people need to be watched closely. And so you need to alert, if you're sending a patient to surgery, one of these patients to surgery, you need to alert the anesthesiologist and the surgeon the fact that the patient has obstructive apnea needs to be watched closely and monitored post-surgery. The other thing is these patients need to be mobilized, Dvt Prevention, stockings if they have varicosities. They're really a setup. Many of them are obese, and they're a setup for DVT and for PTE. So just be aware of that. And I mentioned the types of non-invasive positive pressure ventilation that are available. It's very rare these days that we have to trach patients, but on occasion, patients are so severe with such a difficult time in managing their PCO2 that they have to actually have a tracheotomy. I don't really see that as often these days with the therapies we have. Okay, next slide, Megan. Another problem that the elderly have is a problem with chronic bronchitic problems and chronic recurrent pneumonias. These patients basically develop a lot of chest infections, and it is many times because they have an inability to fight infections. They're older and their immune system isn't as good, but many times it's because they're aspirating. You should especially pay attention to patients who have had strokes, especially if there's bulbar involvement, or patients especially with Parkinson's disease. That's the other big category of patients that tend to aspirate over time. So if you have a patient that has, for instance, Parkinson's disease, and they're having pneumonias or bronchitis every month, that's something that you need to assess to see if they have problems with their swallowing. The other thing that patients have is a problem with reflux esophagitis, and many times they'll reflux. In addition to having gastroesophageal reflux disease, they have a very reduced contraction of their esophagus, and they may have problems with their lower esophageal sphincter, and they'll reflux up to their larynx. So these patients either reflux or they may choke and have difficulty with swallowing. And so if they have a history of choking and recurrent infections or any of those neurologic diseases that might produce this, it's always good to get a modified barium swallow and have the speech therapist there, because you want the speech therapist to be able to instruct the patient in swallowing and assess their swallowing ability. And what do they need? Thickening of their liquids and so forth, which all of you, I'm sure, are aware. It's also good to get a sputum culture from these patients and see what they're growing. If there's something resistant, you need to be aware. And you might want to image these patients because many of these patients have bronchiectasis, and we'll talk about that in a moment. So you might want to do some type of CT imaging. And then suppressive antibiotics, so that there are times when you can do things to prevent aspiration, get speech therapy to work with them, alter their diet and the way they eat and the way they swallow, tucking their chin, etc. You can do these things, but if you've done all the things you can do and these patients continue to have problems, I generally go to suppressive antibiotics. and I'll pick something like doxycycline and use it 10 days out of the month to suppress bacterial growth. We know that these patients grow bacteria continuously. We can never clear their airway. So and they usually infect themselves either from a recurrent aspiration, or they may self-infect from their microbiome in their airway and basically get recurrent infections. So if you suppress them either with, again, the Zithromax Monday, Wednesday, Friday regimen, or using something like doxycycline or cephalosporin or something for 10 days out of the month, I've found that you can keep these people controlled without continually getting infected. And over time, they get stronger and better without exacerbations. Okay, next slide. So this leads us to bronchiectasis, which is a sort of a silent disease that many people don't look at or be aware of, but it's amazingly common in older patients. And you should suspect it when a patient has voluminous daily sputum production. So the two ways you see this, one is a patient comes in and they're always rattling, or you listen to them and they sound clear and then they cough and you hear all this stuff down there. And every time you examine them, you see this. And then the key is to ask them about sputum production, but not only about sputum production, but the volume that they produce. And it's amazing. I always say, you know, how much phlegm do you cough up in 24 hours? Can you fill up a teacup with it? And it's amazing to me. Somebody says, oh yeah, a teacup and more. You know, it's amazing the volume of sputum that these patients with bronchiectasis produce, because the damage to the airway is such that there are increased mucus glands that are produce tremendous amounts of mucus. They just have an overabundance of mucus glands because of the injury to the airway. And it's all these little factories of mucus producing mucus in these folks that produce voluminous amounts of mucus. And if you can keep them clear, they function better. So you outline drainage therapy, and basically that consists of using a flutter valve. So I generally give them a flutter valve, which, you know, vibrates their chest when they breathe in and out. The old percussion used to be the way we went, where we tapped on people's backs with a cupped hand to percuss them and vibrate their chest to loosen the mucus. Now we can use these flutter valves to do the same thing. And then inhaling hypertonic saline, 3% or 7% saline, and nebulizing that will also draw fluid out of the airway and loosen their secretions and help them clear the secretions. So those are the two things that you do in people with tremendous secretion problems, using hypertonic saline, and then the flutter valve, and then drainage. If a patient has it chronically, you might want them to get a tilt table, or they can just lean over, use a wedge or lean over a couch, or prop pillows up so that their head's a little bit lower than their feet. And by draining after they've done the flutter valve and the hypertonic saline, they can get that stuff out in the morning and be cleared through most of the day. Some of them have to repeat it at night as well. So be aware that they may have to do it more than once a day. Another caveat is that if they do the hypertonic saline, it's irritating. So you would probably want to pre-treat them with albuterol before they do the hypertonic saline. But that mechanism would work real well in terms of getting them drained. Then using suppressive antibiotics like I mentioned with the chronic recurrent aspiration or chronic recurrent bronchitic infections. I usually put these patients on suppressive antibiotics, and then bronchodilators if they have an asthmatic component. There are some bronchiectatics that don't wheeze, that don't have asthma, that don't need bronchodilators. But many times, in spite of that, I'll use albuterol before I start for two reasons. One is it does open them up a bit, and the other is before they use the hypertonic saline. I may not use other bronchodilators that are long acting on those folks, or asthmatic medications, inhaled steroids. But if they do have a situation where they do have an asthmatic component, then you probably want to use inhaled steroids with long-acting bronchodilators. It's very important to treat gastroesophageal reflux disease, which is a common cause of bronchiectasis, and evaluate them for that. I usually recommend that people don't eat 3 to 4 hours before they go to bed to give their stomach a chance for gastric emptying. I've come across a few folks that have had problems with gastric emptying, and that's why they've been having bronchiectasis. So be aware of that possibility, especially in diabetics. The other thing I usually check is immunoglobulins, because usually in younger people, not as much in older people, but I still do it. Check immunoglobulins to see if they have an IgG deficiency. And if they do, that may be partially an explanation of their problem, and you can get them to an a rheumatologist who deals with immunologic problems, and they can usually consider IVIG or something like that if they're appropriate. And then many times, if there's any question about connective tissue disease, people with Sjogren's disease or other rheumatologic diseases many times have bronchiectasis, and sometimes you sneak into connective tissue diseases through the back door by finding the bronchiectasis. Okay, next slide, Megan. A very common problem in the elderly is interstitial lung disease, usually, and what I'm usually referring to in older men especially is IPF, idiopathic pulmonary fibrosis. These patients many times have been called COPD because they're short of breath and they may have this dry hacking cough, and they've smoked because their smoking is much more common in patients with IPF. Many times they've been called COPD and treated for COPD when actually they have interstitial lung disease. The other thing to remember is that there are people that do have a combination of these things. They have COPD with, emphysematous changes in the upper lobes, and then in the lower lobes, they have interstitial lung disease, emphysema in the top and interstitial lung disease in the bottom. And so they have both diseases, and you need to treat both. And so if you suspect it, obviously you're going to hear crackles on the exam. And then what you do is you get a high resolution CT of the chest. And there's a classic finding of involvement of the lateral areas of the chest wall along with the bases, with sparing of the central areas of the chest, that is classic for IPF, idiopathic pulmonary fibrosis. If you see the classic X-ray findings in an older male with no evidence of connective tissue disease, and no environmental exposure such as asbestos or borreliosis or something that might have caused them to get interstitial disease, then you pretty much are on sound ground of calling it IPF and treating them without a biopsy. So a biopsy would not be necessary in many patients, but there are patients where there are questions of whether they have a borderline blood work for connective tissue disease, maybe rheumatologic factor or ANA may be positive. They don't really have a history of it, but you wonder if it may be, or they may have Raynaud's, but nothing else. And in those situations, you might want to investigate a little bit further, but most of the time it's fairly clear with IPF. And most of the time, what you're going to be seeing in elderly individuals, especially males, is IPF. But don't forget to get a connective tissue panel. Don't forget to ask about exposures. Now, one of the exposures that everybody knows about is mold. I mean, people can be exposed to mold over time, and they can get hypersensitivity pneumonitis from the mold, not just an asthmatic reaction. And if they do that, then they have to, abate the mold from their house and so forth. Generally, these hypersensitivity pneumonitis problems that many times are chronic and look like IPF are a little different in that they involve the upper lobes more than the lower lobes, which is not what IPF does. And they also have nodules. Many times you can see small nodules in the involvement of the small airways. And the thing to do if you suspect this is to always get an exhalation film. A good exhalation film will show air trapping. You don't see air trapping with IPF, but you do see air trapping with people that have hypersensitivity pneumonitis to a variety of things. I've had patients that are woodworkers that have their own little shop in the backyard, and they have a little barn-like area, and they've been exposed to sawdust and a lot of different types of woods and barks, and they've developed it. The most common thing I see is bird exposure, and bird exposure, not necessarily having a pet parrot, which is certainly a red flag in this situation, but also people that have used down comforters and feather pillows for decades. Those things can produce hypersensitivity pneumonitis, and it can be severe. So it doesn't mean you should never use a down comforter, but there are some people that are very sensitive to those things, and they will get, after using down comforters and feather pillows for decades, they will get interstitial lung disease. So just be aware of that, and I always ask about that. I had one lady that she had down comforter, feather pillows. Her husband hunted, so she had all these stuffed birds in her house, and she had all of her furniture stuffed with down. So she was totally exposed, and we removed all that, and she got better. And her problem was mainly just a cough. That she was on all this therapy for cough, and nobody could stop her cough, and her cough was strictly related to her exposures. So be aware of environmental exposures with interstitial lung disease. Again, what you want to do is to get a high resolution CT scan of the chest and get it on inspiration and expiration to look for small airway disease that can occur with problems such as connective tissue disease or hypersensitivity pneumonitis. The clue is that if there's a significant amount of air trapping, this is probably not IPF, because IPF should not show any air trapping. The therapies for specific etiologies for hypersensitivity pneumonitis is removal of the antigen, and then sometimes people will respond to drugs like Cellcept. Steroids work for an acute hypersensitivity pneumonitis, but they don't really work as well for chronic hypersensitivity pneumonitis. Drugs like Cellcept work real well for that. And then for IPF, there are two drugs, pirfenidone and Ofev. They've been shown both to really slow down or stop the progression of interstitial interstitial fibrosis in patients with IPF. They are basically antifibrotics. They're not anti-inflammatories. So in all the studies that looked at use of steroids and anti-inflammatories, Imuran, those drugs for IPF showed that the mortality increased. So you don't want to use anti-inflammatories in IPF. You want to use the antifibrotics. And that's why today it's so important to know, do they have connective tissue disease where you would use anti-inflammatories with their interstitial disease? Do they have environmental exposures where you would use anti-inflammatories? But you don't want to do that in IPF. So the differentiation of these fibrotic diseases is more important today than ever before. Okay, Megan, let's move to the next slide. So I wanted to give you guys, how much time do I have, Megan, left?
You have, you're pretty good, 30 to 40 minutes left.
Okay, good. So I may not even take that length of time, but basically we'll talk a little bit about COVID because this affects elderly patients more than it does younger people, though I do have a number of younger people that have had severe lung disease related to COVID. You're all aware of the symptoms by now, so I won't bore you with those, except to say that that sometimes it's as simple in older people as fatigue. I had one patient that had a little stuffiness in the nose, his wife told me, but he was getting tired. He was more tired all the time over a day or two. And then one morning he was sitting at the breakfast table drinking coffee and he could not get out of his chair. His wife couldn't lift him because he was very heavy. So she had to call the paramedics to get him up and to the hospital. She thought he might be having a stroke. It turned out he had COVID with severe fatigue, and he developed a COVID pneumonia and had significant problems. Fortunately, he did okay. So be aware of fatigue as a major presenting symptom. Of course, you know about the diarrhea and other things, but that's one thing I've noticed, that older people get a lot more fatigue. You know about prevention. I won't go through that. I just want to mention one thing, droplets versus vapors. You're all aware that droplets are larger particles, and they're the ones that drop out at 6 feet. But vapors don't drop out at 6 feet. So if you think in terms of someone vaping, with one of those vaping devices, and you see them blow that smoke into the air, that's a vapor. And you see where it goes everywhere. So if you're in a room or an area where there's no air turnover, the vapors are what will get you if you don't have a mask. It's not the droplets. So you can space yourself from people, but if they're breathing and talking and laughing and coughing, these vapors are going everywhere. And if the airflow is not appropriate, then you run a risk of catching it. So be aware that 6 feet may not be good enough in a small area with no air turnover. I think the next frontier will be air turnover. That is, I think people should, in the future, pay attention to turning volumes of air over in rooms so that air circulates enough that it clears these vapors and viruses in the air. So that would be a whole different lecture. So the factors affecting severity include age and sex, so that men, older men have more of a problem. Men in general, African Americans have more of a problem. People that are obese, people that are diabetic, people that are hypertensive have more of a problem. And then viral load is an important thing that's been looked at lately. That is that people who get a tremendous load of virus and inhale a tremendous load of virus tend to have much more of a problem than people who generally protect themselves as best they can and inhale a smaller amount of virus. So viral load may become a real key in why people get sicker. It's also how they handle it, because not only is the viral load important, but things like interferon are important. So there's some people that don't produce enough interferon for whatever reason, and there's some people that have antibodies to interferon that the virus triggers. And so they tend not to be able to fight the virus as much because they can't produce interferon. That's one thing that's been recently looked at. I also found an article that I thought was really interesting about testosterone. They looked at a number of prostate cancer patients who were taking drugs that block testosterone, and they found that they were 4 times less likely to get COVID. And if they got it, they got mild cases. So they looked at this, and it appears that testosterone has some action to increase the receptor in the cell to open up to allow the virus to enter. So there may be something about these young, healthy men who get severe disease, and you're wondering why this young man got such severe disease. It may be testosterone related. I've always wondered about that. I only saw one article about that, and I'd be interested to see if there's anything else that comes out in the future. Okay, next slide. So obviously the complications of COVID, prolonged fatigue, simply loss of sense of smell and taste. That happened to me about 20 years ago. I was hiking in the Cascades and got chilled and caught a cold. And suddenly I noticed that I couldn't smell or taste, and it lasted 6 months. And so it obviously was a coronavirus. So this coronavirus isn't the only coronavirus that causes loss of smell and taste. There are others out there that do that as well. But it's really funny to be chewing on something and know what it is, but you can't taste it. And I really hated the fact that I lost the smell of coffee. I was so happy when that came back, but it does eventually come back. Now, the lung involvement with COVID, I would like to break down into 2 types of lung involvement. One is the acute viral involvement of the lung, where the receptor, the ACE receptor, is invaded. The virus enters the bronchoepithelial cells and produces ARDS, blows open the alveolar capillary membrane, and you get leakage of fluid and an acute COVID pneumonia, which puts people on ventilators and kills people. I mean, that's the bad COVID complication. But then people will many times avoid that. They'll get sick with COVID and feel terrible. they'll have fever, they'll just feel horrible, but they won't be short of breath. They'll be doing fine. And then about 6 days into the course of the disease, they start developing shortness of breath and their oxygen saturation begins to fall. When that happens, they're getting one of two things, or one of a number of things. One thing could be, if it's acute, they could be getting a pulmonary embolus. And that does happen. A lot of people will check D-dimers on these patients. They're going to be up because they're having inflammatory problems, so that in itself won't diagnose it. But if you suspect that there's an acute pulmonary embolus, go ahead and scan them with imaging with a CTA, so that you will find out if they have an embolus. But also at the same time do an HRCT, because they may have cryptogenic organizing pneumonia, the old BOOP, bronchiolitis obliterans and organizing pneumonia, that's been renamed. So if they don't have an embolus, but you find these fluffy infiltrates that are based in the small airways and surround the small airways, this is cryptogenic organizing pneumonia. Now, this has a different etiology than the viral pneumonia. What happens is you get an inflammatory response, and there's these inflammatory mediators or cytokines damage the airway and produce these inflammatory pneumonias. So when that happens, it's a separate deal. It's not going to respond to viral treatment. It's not going to respond to antibody therapy. It's not going to respond to infusions of plasma. It's beyond that. This is inflammatory disease that's going to respond to steroids. And so you need to put these patients on steroids. And the one that's been studied was Decadron or dexamethasone, and the dose was 6 milligrams a day. So that if you see someone develop this organizing pneumonia, these patchy pneumonias that are mostly in the bases in most patients that I've seen, then you need to start them on steroids. And you have to give it to them for long enough. Now, many of you have been around as long as I have, maybe not quite as long as I have, but some of you may have been. And remember treating patients with bronchiolitis obliterans and organizing pneumonia of unknown etiology. And probably the etiology was some virus that we just didn't identify. Half the people with cryptogenic organizing pneumonia have an unknown etiology or probably a viral etiology. And the other half are eventually shown to have connective tissue disease, such as rheumatoid arthritis or some connective tissue disease, dermatomyositis. So that if they have an unknown etiology, we would put them on steroids. But we found that if you didn't put people on steroids for at least 3 months, and probably in some instances 6 months, they didn't get better. So my rule in the old days was to take these patients with BOOP and put them on steroids at least 3 months. I would check them at 6 weeks. If the imaging showed that the organized pneumonia was clearing, then I would start tapering their steroids and get them off by 3 months. And that was my general rule. Well, for some reason, people think this is different, and it's really not. So that you don't treat this for 5 days. There are people that come out of the hospital, they have this, they're put on dexamethasone for 5 days, and then it stopped. And of course, they do well for a while. And then 2 or 3 weeks later, I'm getting calls, this patient's sick. And it's just that they weren't treated completely. So if you have someone in this situation, keep them on steroids long enough that you show that their CT scan clears. And then you can start tapering it, but don't taper it too soon. The other thing that I've noticed, there's only a couple of patients I've seen that have small airway disease. They air trap when you check an exhalation film. And these people have significant hypoxemia. The people with cryptogenic organizing pneumonia may have a normal saturation, relatively normal when they're standing around, and you walk them and they drop their sats like a rock and require 2 or 3 liters to correct. These people with small airway disease are hypoxemic from the get-go, and they really are, their sats are in the 70s and 80s, but their x-ray may look fairly clear. And so if you do the exhalation film, you see they have small airway involvement. I put these patients on steroids, and both of the ones I've seen, I've only seen 2, both of them got better with the use of steroids, and their small airway disease improved. As you may be aware, small airway disease does not necessarily improve in other situations like inhalation of certain fumes that will cause small airway damage. But in this situation, it seems to improve with steroids. A lot of times patients have a cough with this that persists. And in some instances, it's cough asthma. So some of these patients, if I'm pushed, I'll try them on inhaled steroids and bronchodilators. And some of them respond, some of them do not. So it's worth trying if you feel like they may have a cough variant asthma as a result of airway injury from COVID viral infection. You're all aware of the vascular and pulmonary and arterial thrombosis problems. You can get brain clots, you can get clots in the lung, you can get pulmonary emboli, you can get strokes, renal failure. All these things can happen. So just be aware of that, and they may need anticoagulation. That's sort of the scary thing. There are studies going on looking at thrombosis and ways to alter thrombosis. These studies are in COVID patients, and these studies are ongoing. I haven't seen, I think the one I'm thinking about is in phase 1. So pay attention. There may be something coming out that may be effective for that part of COVID. The cardiac failure and arrhythmias is the other interesting thing about COVID, in that patients can actually go into heart failure. I've had a couple of patients that have had pulmonary problems and also cardiac failure who have required cardiac therapy for heart failure. It's too early to know how well they're going to reverse in terms of the ones I'm seeing. Also, arrhythmias are common, especially if there's a prolonged QTC, and that's why it was so risky to use Zithromax and to use hydrochloroquine, which both prolong QTC intervals. And if patient already has that, they can be at risk for ventricular arrhythmias. And neither one of these drugs have been shown to affect COVID, so most people are not using these anymore with COVID patients. But interestingly, I've seen other types of rhythm problems. I've seen one patient that had a heart rate that was normal before COVID, and then her heart rate fell to 40. She was in sinus rhythm, but she was at 40. And it was sort of scary. Her Holter monitor showed that it was all sinus rhythm. And eventually, after 3 or 4 weeks, her heart rate came up into the 60s. But that was bizarre. And then the most common thing is tachycardia. So many people have a sinus tachycardia that won't go away. They're well in every other way, except if they walk, they get real short of breath and their heart rate jumps up to 160. And I treat these patients sort of like a sympathetic overdrive. I put them on beta blockers, and they seem to do well on beta blockers. Basically, it slows their heart rate, and they're much more functional with beta blockers, and their shortness of breath gets better. So it's just something to think about. There are people that just get a plain sinus tachycardia that just will not slow up. So this bug also affects the conduction system as well. Okay, let's go to the next slide. So you're aware of the vaccines. You know, the mRNA vaccines are the Pfizer and the Moderna. The DNA vaccine is AstraZeneca. It basically is a adenovirus that has incorporated the DNA of the coronavirus. And so you're injecting an adenovirus into the system. The adenovirus invades your cell and releases the DNA, but doesn't replicate, they say, and I'm assuming that's true. There are other vaccines that have used this same mechanism of delivery, so it's not something new, but it's different than the others, so just be aware. And then there's a new vaccine that's in phase 1 that's a protein vaccine. Basically, it is the protein sequence that the mRNA produces through the ribosome. You just have that protein, and that protein is the vaccine. And so it's been shown that, and again, that's I think in phase 1. I don't know if it's moved to phase 2 yet. But when that one's developed, it doesn't have to be refrigerated. It lasts a long time, and that's the one they're probably going to be using in third world countries because it'll be so easy to deliver. And it gets the highest level of antibody response. So this protein vaccine may be pretty good in the future. So just pay attention to that. You know, most people, conservative measures, vitamin, zinc, all that's okay. I tell people they can do that if they want. And then the isolation, 10 to 14 days, most people are saying it moved it back to about 10 days to isolate. I always have patients follow their pulse ox readings because many times that's the first sign that they're going to get this inflammatory pneumonia. So if their pulse ox measurements are falling into the low 90s or 80s, they should call me and I image them immediately. And then I use steroids at that point. You don't use steroids early because it ain't gonna make a difference if you use them early in the course. If they're going to get well anyway, there are a lot of patients who are going to get well anyway, so there's no sense in putting somebody on steroids if they're going to get well. We know that I talked about zithromax and hydrochloroquine, that they don't really work. There are a number of other things that are out there that probably don't work as well. The antibody thing is still up in the air, antibody infusions. But if they do work, it would be early, like within the first few days. We don't know about long-term pulmonary disease. I have a few patients that I've cleared their organizing pneumonia and they're left with fibrotic change. And one of the patients has remained on oxygen because he has fibrosis. So there are people that are going to get chronic fibrotic change, but fortunately, that's a minority. Most of the patients I've seen with this clear totally, and they don't get problems down the road, at least that we know of right now. So I'll stop with that and see if anybody has any questions or comments. Megan?
All right, we do have a few. Yates asks, what is the best way to collect adequate, believable sputum samples from elderly patients?
Probably induced sputums are the best way. If you can get a good induced sputum by, nebulizing albuterol or saline or something to make them cough, that would be the best way. There's some patients you just cannot. I mean, they're going to cough and swallow. They don't cooperate. But the best way is an induced sputum. And so I will send them to the lab with a cup, and after I induce the sputum and then do it. The problem with induced sputums now is that if we do that in the clinic, we have to close that room because it aerosolizes things. So we have to close that room for a few hours to let the air circulate in those rooms. So that's the downside of inducing sputum at this point. I would suggest that there is a sputum you can order, a cystic fibrosis culture. So if you're really wanting to get a good sample, you can't really get quite as good a sample. Then you get a sample and they send it back. Epithelial cells, won't culture for you. If you get a cystic fibrosis culture, many times they'll culture it anyway and they'll hold it for longer. So you may grow something with a cystic fibrosis culture. If you tell the lab you want a cystic fibrosis culture, they treat it differently. And so if you order a cystic fibrosis culture, you'll probably get a better chance of getting good organisms.
All right. Next question, Dr. Uford. Is the primary reason for long-term use of inhaled steroids in asthma to prevent bronchial inflammation progression to scarring and COPD?
Well, the primary use of inhaled steroids is to reduce airway inflammation, so that if you don't reduce airway inflammation and shut down eosinophils, shut down cytokines in their reaction to the airway, what happens is that chronic airway inflammation will eventually produce increased mucus gland production, and so you'll have increased mucus. In addition, it'll thicken the basement membrane and increase the musculature of the airway, so the airway will chronically narrow, and this is called remodeling. So if the airway remodels and it becomes more narrow, you have a smaller airway to begin with. And if they get an asthma attack and get inflammation from an acute attack, they really close their airway, whereas opposed to someone who has a normal caliber airway after using inhaled steroids for years, their airway remains wide open and they don't have as much of a problem when they have an acute attack. So it's to prevent remodeling of the airway. Now, in terms of COPD, people generally don't get emphysematous changes with asthma, but if they do get enough small airway involvement because they weren't treated appropriately with inhaled steroids or they really weren't controlled at all, then they may get enough small airway disease that they air trap and they get almost an emphysematous change, but they don't get the damage to the alveoli that people with COPD do. So it's sort of a different reason that they become hyperinflated. And many people will call that emphysema, but it's not the same thing. It's from a different mechanism. But predominantly, most people get airway remodeling and changes in the airway if they're not treated with inhaled steroids. Okay, Megan.
Next question, still from Dr. Uford. How do you use disease intensity markers such as ferritin, CRP, LDH, D-dimer, etc.?
Okay, so inflammatory mediators are good. With asthma, I like to use other things, basically looking at eosinophils and looking at exhaled nitric oxide, which is an indication of control of asthma. So those are two things that are really nice to look at with asthma. In terms of D-dimers and inflammation, that's so non-specific that I really don't use that a lot. But with asthma, following those things are pretty good. And you can basically decide if you're controlling the asthmatic with inhaled steroids and other medicines, montelukast and other medications. And if the eosinophil count is down, then you're doing a pretty good job, especially if they're not symptomatic. Otherwise, you may have to resort to drugs like Nucala, IL-5 blockers, or IL-13, 4 blockers. These are available in injectable form. And if you've done everything else and they still aren't controlled, that's where you would move. So those are the things I sort of follow.
Okay. Next question. What is the plan with decreasing the oxygen liters with patients that are recovering during the 3 to 6 months? Many I have found have fared to go down at all, remaining on 3 liters.
Okay, so as I said, I have, a few patients that what I do is I re-image them and see if they're developing fibrotic change. And there's not anything I can do about that. Many times in both of these patients, I've tapered their steroids because the steroids were the fluffy infiltrates of the organized pneumonia were gone. They were just left with fibrotic change. The other thing is to, again, like I said, look and see if they have small airway disease. So get a good high resolution CT of the chest on exhalation and see if they're air trapping. And if they are, this may be a problem that may not be fixable. I don't know this yet because both the patients I had did improve in their air trapping with steroids, but I can assure you there will be some that will continue to have small airway disease, and these people have significant hypoxemia that will not correct. So I would get a good high resolution CT scan of the chest, make sure they exhale, look at the trachea, make sure it collapses on exhalation on that film, make sure the radiologist did it right. And if you see air trapping on that film, then you've got to suspect they may have small airway disease, and look for interstitial disease as well. And also make sure they've cleared the organized pneumonia. Like I say, I remember patients that had to go 6 months on steroids before they actually totally cleared their organizing pneumonia.
Okay, we've got about 5 minutes left, so we have one more question. What are your thoughts about the use of monoclonal antibodies for treating mild to moderate COVID-19 in nursing home residents who are at high risk for progression?
I think it's a good idea if you catch them in the first 2 or 3 days. Beyond that, if it's day 6, 7, 8, it's not going to help. And if they're already on oxygen, the study that looked at antibodies, one of the studies that looked at antibodies showed that when they treated patients in the hospital that were sick on oxygen, that they did worse with antibody therapy. So remember, the antibody therapy is not going to help down the road because the problem is not related to the virus, it's related to an inflammatory response with, the cytokines like IL-6 and those things. Those are the things we need to be blocking. And I think there's studies that are looking at that to block those type of responses, the inflammatory responses down the road. So yes, I think it's worth trying antibodies early, but if the patient's 6 days, 8 days out and they're sick, it's probably not going to help them. And then you need to image them and probably need steroids at that point.